Thank you very much. When my colleagues see me dressed in this outfit, they usually figure I'm either going to a funeral or giving some kind of a presentation. And actually, it's perhaps more of a wedding outfit right now as we talk about how our different services work together, although with all the people that are working together, it would be more like a polygamous type of marriage than anything else. So I'm going to be talking about how we provide service at the Royal, and then you'll hear from some other sites as well how they provide services, and I'll talk a little bit about my own background when I get to the slides that refer to what I actually do. But I think the other thing I want to do right at the beginning is sort of a happy announcement that I can make. About a year ago, the Royal College of Physicians and Surgeons of Canada approved a new subspecialty in overall in medicine. So medicine are things like internal medicine, surgery, etc. I'm part of the group for psychiatry, and within psychiatry, we now have some subgroups, and one of them is geriatric psychiatry. So we can actually continue on the type of work we were doing to train subspecialists, but perhaps at a more rigorous level. And about 2 weeks ago, at our University of Ottawa, we did get approval from the Royal College to go ahead, and we do have a resident who plans to work with us as well. And so this is something that hopefully will roll out across Canada. Toronto has a program as well, and many others are applying at this point or waiting for approval. Anyways, coming back to here, so I'm going to be going over services that we provide at the Royal. So we'll talk about who we serve and the kind of things that we offer. So to start off, and this is probably pretty similar to most of the areas, patients over 65 with mental health illnesses that require specialized psychiatric care. And the reason for putting that in is that primary care physicians can actually take care of a lot of the psychiatric problems at all ages, and we certainly collaborate with them in that respect, even at the level of education. But we're there for when things become much more difficult or complex to deal with. We do deal with patients under the age of 65, but provided that they suffer from an age-associated psychiatric illness. And often we're asked, how come not more than that? The reason for that is that there really are enough psychiatrists in the community that ought to be able to deal with the people under 65 compared to the small number that are primarily devoted to those over 65. We provide services in both official languages. We do try in some of the others if some of us are available who can speak other languages. For us at the Royal, we do require that the patients be referred by a primary care physician, a family physician preferably, and that's because what we want to be able to do if we're going to be following this patient is concentrate on the psychiatric problems and not become their family physician. If we do that, then we cannot provide as much service as we would be able to. We would start to have what we do diluted by other problems and not be as available as we are. Most of the people that we see are quite complex, so they usually have anywhere between 2 and 4 psychiatric diagnoses. So that would be often some form of cognitive impairment, one of the dementias usually, another disorder such as depression, and often there is things like substance problems involved, insomnia, etc. So we're looking at many different areas. And also most of the people that we see have numerous medical problems as well, cardiac problems, neurologic, etc. So it's really a complex, and that also highlights why it's so important for us to be able to work with primary care physicians because of all the complexity of the medical problems as well that we're dealing with at the same time. So I'm going to go now through some of the individual programs as listed here. Our ambulatory care services, or what most people think about outpatient services, but we include our day hospital program in there. The outreach services, which here means that we are going out of the hospital at the sites where the patients are, or in the rural areas, we're trying also to provide some help to hospital-based settings. Dr. Shea will say a little bit more about that. Inpatient services and other kind of things that we do as well. So first of all, outpatient services. This is run by Dr. Kathy Bradick right now, and they provide consultation and treatment in the outpatient setting. So these are patients who come with usually a power of attorney, caregiver, family member to our hospital and get the assessment here. There is a team that works here, and we've been very lucky to be able to get support for this team over the past few years. And instead of reading all the different people that are in the team, they're all important, but just so that I don't spend a lot of time reading everything that's on the slides, it's listed there who's part of this team. Probably what's more important to know is that we deal with a lot of patients. We have about 300 new referrals a year, and we've listed the current waiting time. So for an urgent referral, we can expect that within 2 weeks that we would be able to see them, and for an elective, less than 2 months. And that's quite a bit better than the kind of numbers most people attribute with what psychiatric services can provide. And of these people that we see in consultation, there are about 900 overall that are followed on a more or less regular basis. Now I'll turn this over to Dr. Shea.
I did not wear my funeral suit today. Yeah, I know. So I didn't get the memo about wearing somber colors and suits. So I'm Dr. Kathy Shea, and I wear many hats here at the Royal. And one of the hats I wear is as Service Director for Rural Outreach. And I'm going to start off by apologizing that this slide and what I'm going to say is so Royal Ottawa-centric, because in fact the piece that we provide to the rural teams is just that we send out psychiatrists to connect with extremely hardworking teams who are based in Pembroke, as for the Renfrew County Geriatric Mental Health Team, in Cornwall, where we have 2 teams, one providing services to community-based elderly, and one providing services just to the long-term care homes there. We provide the psychiatric component or the psychiatrist component to in Smith Falls to the Lanark County team, in Brockville to the Leeds-Grenville team, and while we don't have a representative from the Montfort today, geriatric psychiatry is represented through the Prescott-Russell outreach team through the Montfort. I'm going to speak first about our day hospital services here, which are available to the entire Champlain LHIN, but since they're based here, it makes it a little tougher for people in the rural communities to come in for 2 days a week. We have 45 spots in the day hospital, and the patients that we see usually require intensive assessment and treatment, but it is deemed that these patients can live safely in the community while those services are being provided. And the referral sources for day hospital are geriatric psychiatrists. That does not mean that a community-based physician cannot send a referral requesting an assessment for that service, but because we have so many referrals in such few spots, we do try to make sure that we accept those patients that we're likely to be able to help. We are very lucky to have a very extensive, but of course not enough, members of our multidisciplinary teams. In the course of a year, we usually have about 100 patients roll through with an average length of stay of about 16 weeks, and that has changed in the past few years. As we've developed the service, we have seen more and more patients with cognitive impairment complicating the psychiatric aspects of their presentations. And so the length of stay has increased a bit more as the recommendations and supports are a bit more complicated. The average wait time for an elective referral is about 60 days. The average wait time for an urgent referral is about 20 days. And in the past 12 months, we have usually run at over 100% occupancy. It's a complicated story that I won't bore you with, but it has certainly added pressure to our very hardworking team. And I'll turn it back over to Dr. Lee.
So the next two slides refer to the outreach program, and this is certainly where most of the patients that we see come from. So even though we're talking about the Royal, our geriatric program has truly become more of a community service rather than an in-house service. So what does this mean? So in the Ottawa area, things are a little bit different from what the outside of Ottawa area, what I'm going to be referring to rural, and Dr. Shea will go over that a bit. The Ottawa area, I'm the service director of this program. I've been doing it for almost about 10 years. And we provide consultation and treatment in all the 28 long-term care homes, or what people also refer to as nursing homes. These are not residences. These are actually where much more nursing care is required. And each of the homes is visited at least monthly. The larger homes, it can be twice or even 3 times a month. Up until very recently, we had 9 nurses involved. And because of a lot of lobbying that's been happening for years on the part of anybody who works with elderly patients, and the unfortunate situations in long-term care that are being referred to as murders, there's been a recognition that increased amount of help is required at this level. So in Ottawa, we've been able to very recently expand the number of our team up to 16 nurses. The new ones are currently being trained in long-term care facilities with nurses who have been going there for several years, so that we can provide more timely advice and also more education to the staff in the long-term care, which includes looking at what they do and trying to help them learn from their hands-on type of interaction with patients in the long-term care facility. In Ottawa, there are over 4,500 nursing home beds, and we follow about 25% of those people. And although that sounds like a lot, that's probably lower than it should be given the number of people with dementia in long-term care facility and the rate at which problems such as agitation happen in these people. The average wait time is about 16 days, and the reason for that is because on average maybe we're in any home 1 to 2 times a month. It ends up about the half of the interval that we're seeing them in. So we can usually follow up on these people pretty quickly.
So the rural outreach program, as Dr. Wiens has indicated, is a little bit different, and consultation and treatment are provided in all settings in slightly different ways depending on the center, but consultation and treatment is provided in clinics, in private homes, retirement residences, all of the rural hospitals, and in 33 long-term care homes outside of Ottawa in the 7 rural counties. We have 8 psychiatrists that go out from the Royal Ottawa Hospital, supporting in those different regions 20 team members in 4 multidisciplinary teams, as I mentioned, based in Cornwall, Pembroke, Smith Falls, and Brockville. I actually do not know the numbers for Prescott Russell, so hopefully on a future run-through services we will be able to have someone from the MOF4 here. So on average in those settings, we have 2,000 unique patients seen per year, an average of 750 consultations per year, so that would be new consultations. And in those rural settings, 480 clinics are provided per year. I like to say, I was called by Kelly's predecessor the Queen of the Counties, and that was because I happened to be the first to go out and start to connect with teams in the rural areas, and kind of semi-retired from that task when I reached about 300,000 kilometers on my car. So it's a very intensive experience to connect with these teams, because it usually starts with a couple of hours of driving in the morning for the psychiatrists who go out and ends the day with a couple of hours drive to get back. The team members in those centers in the meantime hold the fort between clinics and do an amazing job.
So when you consider the number of people that we see in consultation and that we follow, this slide would, and when I give this information to people, they're often very surprised to find out how small our inpatient is relative to the number of people that we follow. So we have 43 beds, and that's it. And that also provides an answer to a question I hear quite often: why don't you just admit this patient? Amazingly, with most of the people that we see, we can manage them on an outpatient basis, and they do extremely well. But in any case, there are some people that their condition is so severe, they become so exhausting as a result of the condition to the caregivers that they need to be admitted so that we can look at what's going on to be able to help them. We have a large team. Again, I'm not going to read everybody who's listed in there. We have an average of 264 admissions per year. People stay in hospital a little under 2 months, and the occupancy rate is 98%. Why isn't it 100? Because when we discharge someone, there isn't always someone available, even though we have a waiting list. The person on the waiting list sometimes isn't able to come that day that a bed is available, even though we try to do that as much as possible. The average wait time for an elective admission, only 2 weeks. For someone who's urgent, this looks sort of amazing, but that's actually what we get out of our database: 4 days. So for the people that really need to be admitted, that we know we can work very quickly to have them come in. The other kind of services we provide is, as Dr. Shea was referring to, there's some support available to all hospitals in the Champlain LHIN, except CHEO, obviously. We are developing a consultation team to go into the Queensway Carleton Hospital. I actually provide consultation services at the Geriatric Assessment Unit, both their day hospital and their inpatient unit. And we also have a francophone team that flies up to Timmins to do consultations there. Here's a map of the area that we cover. The spots that are highlighted are all the long-term care facilities or the nursing homes, and it gives a bit of an idea of the breadth of the area that we cover, and the reason why, as Dr. Shea was mentioning, you can rack up 300,000 kilometers driving around it, and perhaps Consumer Reports would like to use you as a test driver also, to find out which cars work best.
So in addition to clinical assessments and treatments, we also provide an education service. And I think Dr. Tremblay actually counted up all of the providers who are supplying education, even if it happens to be at the bedside, all the way to formal educational presentations, and 120 either Royal Ottawa Geriatric Psychiatry Program or our partners in the rural communities are providing interdisciplinary education. Another hat that I wear is as director of the CIF education program. And just quickly, that was a fund that was started on a kind of one-time basis when they decided they were going to close Brockville to supply some education for communities in the Champlain LHIN who would be receiving patients who had been treated for years, elderly patients who may have been treated for years residing practically at Brockville. And somewhere along the way, we don't question it too intensely, it became an ongoing fund that we receive every year. And so in the last few years, we've been able to provide more than 60 education sessions, formal education sessions, of gentle persuasive approach, or PIECES, which are approaches to patients with dementia. And in the last 2 years, we've provided that to more than 600 participants in the Champlain LHIN. We also have, we're lucky to have coordination with 5 PRCs, or psychogeriatric resource consultants in the LHIN. And we also, as a site, provide clinical training for undergraduate medical trainees, nursing, occupational therapy, recreation therapy, and social work students. We supply at least education to 16 residents in psychiatry, family medicine, or geriatric medicine. And through our Monday geriatric psychiatry rounds, try to supply continuing education activities of a multidisciplinary nature, again, to everybody in the LHIN. And through OTN, we've had people join us from outside the LHIN for those rounds. And that's who we are. And then you're going to, okay, and I'll leave. Are you next, Dr. Gabessi? Okay.
Thank you. Good morning. It's a pleasure to be here. It's nice to see everyone on such a beautiful sunny day, especially after all those cold, rainy days we've had. So I'm Linda Gobessi, and I'm a psychiatrist, and I'm the medical director of GPCSO. So I'll just briefly review our services. So we're a community-based mental health program. We're funded directly by the Ministry of Health and Long-Term Care, and we're located at the Briere Continuing Care Hospital, which is in the Byward Market. It's a bilingual program. We have a case management model with an interdisciplinary team. And the unique feature of our program is that the clients or the patients are seen at home by the case managers. So that's what's really unique about our service. It's a specialized geriatric psychiatry. It's primarily outreach team. Psychiatrists generally see people in the clinic. Occasionally we'll do home visits, but it's the team that's going to the home, making the assessment at the home and doing the follow-up in the home. We provide support to the caregivers and the family and try and help them implement usually the recommendations from the team and the services. We're collaborating with the family physicians, other services, and community agencies, and we also provide education to other professionals, students, and the community at large. So we also have a psychogeriatric resource consultant who helps with training some of the assisting some of the staff at the retirement homes, also has done series for the police, and we have family medical residents that come through our service on a regular basis. We're going to be starting to have some psychiatry residents, and we have students of other disciplines, social work, nursing, and OT. So our main goals are to improve the care of the elderly in the community, looking at optimizing their mental health, enhancing their environment, linking them to some of the community resources, and that sounds simple, but that's actually requires usually a lot of advocating and negotiating. So many times we'll have patients that have been referred from the RGAP program with recommendations, but it's actually been difficult to implement those recommendations. So it's really trying to facilitate the family and the caregivers and the other services to be flexible and to understand what have been some of the barriers. We're also generally looking at trying to prevent unnecessary hospitalization. So we work quite closely with the geriatric emergency managers in the acute care hospitals and trying to link with them and flagging the individuals that are at high risk. And also at times we are facilitating hospitalization when that's required, and we'll be working closely with the Royal Ottawa. So who's our staff? We have an executive director, we have a medical director, we have a clinical coordinator, and at this point we get on average 120 referrals every month. So our clinical coordinator is key. She reviews all of the referrals and is really looking to ensure that they're appropriate for our service, and she will assist people to try and link them to the appropriate service if we don't think we are it. And we also triage, so we can try and see the people that do need urgent services as soon as possible. And she also provides supervision to our other case managers. So right now we have 2.6 full-time equivalent psychiatrists, and we'd love to have more, and we certainly need more. We currently have 18.6 case managers, and this is a combination of nurses, social workers, and occupational therapists. And that includes 4 new positions that we just got through the Behavioral Support Ontario program that Dr. Wiens was referring to. We also have a psychogeriatric resource consultant. There's 2 people that are filling this position, and we have our valuable medical secretaries that make everything work. So who is our target is people over 65 with mental health problems, and that includes dementia. It's complicated with behavioral and psychological symptoms. We do see some people less than 65 if they have Alzheimer's disease or frontotemporal dementia that's also complicated by behavioral and psychological symptoms. And we've made those criteria fairly strict. There are a lot of people that are under 65 that have had strokes and have cognitive problems and behavior issues, but we would be completely inundated. So we've drawn the line there, and as Dr. Wiens was saying, we're trying to help support the community and allowing them to treat the other patients. People have to live in Ottawa to be seen by the team. We will do consultations for people outside of Ottawa, but we wouldn't be able to follow them. And people have to be referred by a physician, although there are exceptions to that. We are sometimes seeing people that haven't seen a physician for 20 years and won't go out of their home to see a physician. So we'll be trying to link with them and see what we can, how we can best serve them. Family physicians are still our primary referral source. We work very closely with the Memory Disorder Clinic because it's also at Briere Continuing Care. We have a number of referrals from the geriatric day hospitals, from the geriatric assessment outreach team, and from the geriatric assessment unit. Also the acute care hospitals from their emergency rooms, but also oncology and dialysis unit tend to refer to us a lot. Certainly the CCAC case managers, they'll be often initiating the referral and linking with the family physician and the mental health crisis team as well. So it's a client-centered, collaborative, try to be sensitive to the unique needs of the elderly, and particularly trying to break down some of the barriers that make it difficult for them to receive care. We have case conferences within our team. We meet on a weekly basis to review our clients, and our case managers, if available, will also attend case conferences, sometimes at the GAU or at the acute care hospitals at the time of discharge, trying to make that link and that transition. So what do we actually do? So we're establishing diagnosis, providing follow-up, monitoring the treatment, providing education and support, which is really a big part, as we have a lot of individuals who have dementia, and their whole family and caregiving team is important. And as I was mentioning, facilitating the acceptance of services. So a lot of times services are recommended, they're not easily accepted, and we often need a few trials at implementing that. What are the main diagnoses? Certainly people with anxiety and depression are a big bulk, and the other is the dementias. People who aren't appropriate, those who are presenting with memory problems but don't have any other behavioral psychological symptoms. People who have multiple unstable medical conditions, probably we should not be the first route, and people who have mental illnesses but are less than 65. And here's just a list of all of our partners. That's it. Thank you.
Thank you very much. So I'm quite excited to be up here to speak about the LISA program. So the LISA program operates out of the Centertown Community Health Center. My name is Dallas, and I am the team leader of the program, and I also work clinically in the gambling aspect of the program. So we are a specialized community-based addictions treatment program for adults over the age of 55. So we do have the two aspects of the program. We have our substance part of the program, and then we have our gambling part of the program. So we offer age-specific services to adults over the age of 55, both in English or in French, anywhere in the city of Ottawa. So the LISA program operates on a harm reduction client-centered model of care with the overall goal of improving physical, psychological, spiritual, and environmental health of older adults. So I just want to do a quick word on exactly what harm reduction is, because sometimes I think there's a little bit of confusion about harm reduction. And so when we talk about harm reduction, we are talking about a process of change that can include abstinence. And for a lot of the clients coming into the program, they come in, they're not quite ready to give up their alcohol use, their drug use, their medication misuse, or their gambling, but they're willing to accept services to learn ways to reduce the harms. They're looking at exploring other things in their life to sort of improve their overall well-being. And eventually, by the time that they finish the program, the majority of those clients do choose abstinence as the best way of controlling it. So our program is made up of a variety of different components. The main component of the program is individual counseling. And so clients are seen individually by a counselor. We have 4 clinical staff at our program, so a very small team, and a half-time recreation therapist. We see probably just over 100 new clients each year, and a total of just over 200 in a year time frame. Average length of stay in the program is about 2 to 3 years. They come into the program, they go through stabilization assessment, then there's the treatment part of the program, and then there's also an aftercare, follow-up, discharge planning, getting them back into the community, building back their independence. So the individual counseling is the biggest part of that component, and the client is assigned a counselor, and the counselor follows them all the way through their time with the LISA program. Those services are mostly offered in the client's individual home, so just over 50% of our visits are done in the client's home, and the rest of the visits are done in a variety of locations around Ottawa. The main office is the Centertown Community Health Centre, but we also have a satellite office in both the East End and in the West End. So our individual counseling program is complemented by our psychoeducation